So by the end of the day or by tomorrow, I think most of the treatment options that are available for neuroendocrine tumors are going to be discussed in detail. The issue is, when to use what, and what are the sequence of events, and how does surgery fit in with chemotherapy, with radioisotope therapy. And I'll have to tell you that I'm not quite sure that we have the answers to all of that. Although we've been using a lot of the therapies for a long time, I don't think that we've properly sort of studied them. At minimum, we have to start looking at these things prospectively. That means we collect data on everything that we do real time rather than looking back at things, because often a bias enters into the equation if you're looking backwards at things. And whenever possible, if we can actually do trials, randomized treatments, treatment options, I think that'll give us the best answers. So what I'd like to do is just sort of give you several slides on what the treatment options are that are available, both the destructive, what I call destructive treatments, which are surgical and hepatic artery embolizations and ablative technologies, versus systemic therapies, which are more chemotherapy and based approaches, and then try to just sort of fit it all together. And when we fit it all together, it's not written in stone. It's just something that I use, that I kind of think of as I'm thinking through these therapies. And then I just want to point out that it is possible to do these things in a randomized way, in a controlled placebo fashion. And there are two trials that have been done and completed that way. One, the data is already here, and one, the data is on its way. And I'll just mention that too. And I could do this in about 5 minutes so that we'll catch up on time. So if you look at the cellular reduction sort of therapies or the destructive therapies, so we have resection of the primary, which is something that we encourage. If at all possible, we would like to remove the primary tumor, even if there's metastasis present. And then, if at all possible, we resect metastatic disease. And as there'll be talks in the next session that can define, how extensive a resection we can do. Local ablative technologies include radiofrequency ablation, and more recently now we're also using microwave technologies. Some of the microwave technologies make up some of the deficiencies that the radiofrequency approach has. One of the problems with the radiofrequency approach is that if you have large vessels next to the tumor, that the tumor doesn't get cooked well enough or destroyed. Microwave answers those type of issues. Hepatic artery interventions, and that's basically a radiological procedure where we go to the angio suite and we cannulate the hepatic artery, and we can then treat the tumors through that approach, whether it be we put particles in to cut off blood supply to the tumor, whether we put various chemotherapy agents in to treat the tumor locally, a higher dose than we'd be able to do by giving systemic therapies. And something that Dr. Hassanan is going to talk about later that we've been performing at McGill is radioembolization, where the particles that we put in have our particles have yttrium, which is a radioisotope. The other thing that's coming down the pipeline, and we're also using a lot more, specifically our group at McGill and Princess Margaret, we have a couple of trials that are going between the two centers, is external beam radiation. And that's something that in general we use in the liver and has not been able to be used prior, let's say 5-10 years ago, because the radiation was very diffuse that we were giving, and would give a hepatitis, would inflame the whole liver. Whereas now we're able to target it a lot better, so that we're hitting the tumor. And we have seen some extraordinary results with this type of approach. And the last option is that I put down there for destructive therapies, a sort of complete destructive therapy, where you can transplant the liver. And in fact, I am a transplanter by training, and actually my first encounter with a neuroendocrine tumor was when I transplanted somebody with it. But of course, that's the rare exception, that we offer transplant in those cases. Now, in terms of systemic therapies, we have what we can call the biotherapy arm, and that's basically the somatostatin analogs, and that's been around for a long time, mostly used for symptom control and carcinoids. But as you know, with the ProMed data, I think we've gotten over that hump, and I think that many of us will use this therapy as an anti-proliferative therapy also. The cytotoxic chemotherapy, really the only place where it is poorly differentiated high-grade tumors. Then we have radiopeptide therapy, which will get a very good overall view of what's been going on in that area. And then something that's relatively new, the targeted therapies, which I alluded to before, and there are two trials that have occurred already, tyrosine kinase inhibitors, one with tyrosine kinase inhibitor, SUTAN, and the other one, an mTOR inhibitor, RAD. Like I said, the data on the SUTAN is in, and mTOR has been completed, the mTOR trial has been completed, and we're awaiting the data from that. Now, if you look at you follow these lines here. Just that's I love Max. So if you follow these lines, well, first of all, as we go from my right to my left, or your left to your right, this is time passing after diagnosis and tumor progression. So I try to put sort of all the possible treatments, and again, you're going to get more detailed explanations about each treatment as the day goes on. But it's not a bad thing to have this in mind as all the speakers are talking about their specific therapies. So biotherapy can be given sort of all along as a background treatment if you have disease, especially now that we have evidence that there's an antiproliferative effect to these analogs. But at the beginning, I think all the destructive therapies are very important. I think we have to debulk the tumor as much as we can, if appropriate, using surgery, local ablation, and hepatic artery embolization. And then, we do have external beam radiation that's coming down the pipeline, and I hope it becomes more common as we move along. And then, the last option, the Steve Jobs approach, I guess. Your chemotherapy can be given any time if you have a high-grade tumor. And occasionally, as you're progressing, some tumors will change from low-grade to high-grade. So you have to be aware and maybe biopsy a little more frequently than we have in the past to determine if something's changing. And then the radiopeptide therapy. In general, in Canada, we kind of leave this for almost a last-ditch approach. And in fact, why that is that it's not that available to us. So I think, I'll defer to people who have a lot of experience with this, but I think that maybe one approach is to use these therapies, this type of therapy, a little earlier than we've been using it in Canada. And then we'll see where the targeted therapies fall into place as time goes on. So, like I said, the TKI trial is in. So it was basically a placebo-controlled phase 3 randomized double-blind trial. Now, a lot of the sort of preliminary slides I'm going to go through. I'm going to quickly because it's already sort of been talked about. Sorry, let me just go. That's a little bit too fast. Oh, well. How did I do that? I went all the way. I want to go to the beginning, or go ahead. One more. Yeah. So when you take a systematic approach to a substance that you want to use as a treatment option, you do preclinical work, usually in some sort of animal model or cell culture. So that's what was first done with sunitinib, and it was found to be promising. Then you do a phase 1 and a phase 2 trial to actually see if there's any potential for efficacy, and also that the side effects are livable, if you will. Oh, thanks. So basically what was done here was the patients were selected to be well differentiated, but showed signs of disease progression in the last 12 months, and that were not amenable to any sort of treatment that would be with a curative intent. And then they were randomized on a 1-to-1 ratio to one arm with the treatment and one arm with placebo, and progression-free survival was the primary endpoint. In February 2009, the Data Monitoring Committee, the DMC, sat down and reviewed results, showed that toxicity was acceptable and that the study had met its primary endpoint. Therefore, there was a recommendation to stop the trial. And, well, there's a demographics. I'm just going to show the sorry, it's not going as well as it. Can we go forward? There's a graph. There we go. So this is the graph with you can see the two arms. So you have a median progression-free survival of 11.1 months in the treated arm, and compared to 5.5 months in the untreated arm, with a hazard ratio of 0.397, highly significant. So this is where it was stopped. Now, how all this is going to fit and how some of the other targeted therapies that are coming down the pipeline are going to fit really has we still have a lot of work to do ahead of us. What we do know is that these substances are going to be efficacious, so we need to fit them into our treatment plans somehow. So I'll leave it at that, and we can all sort of come up here together, and if there's any questions for the three of us, we'll be happy to take them. Thank you.